So we're really creative. We go walking in the woods to relaxation, to talking therapies, art, gardening. We've got a bit of an allotment going up on the site as well. Got staff trained in Indian head massage, Reiki, reflexology, only she just got pinched from me to the eating disorder unit. What was I saying? Indian head massage, Reiki, Tai Chi. We've got sunken trampoline. We've got rebound therapists. We've got staff trained just to use the trampoline, so it's not a wasted resource. Staff are just actively getting sponsorships to raise money for outdoor gym equipment. Just things from when you walk onto the lodge, you don't see a stereotypical photo of an acute nurse. You see a picture of Peter Marshall in his reserve fireman uniform. You see the pharmacist up there hugging a melon on holidays and Mark swimming with a dolphin. Because it's about being human and about taking yourself into the environment. So I've got a 34-year-old female. She's got a diagnosis of paranoid schizophrenia, and she's got a personality disorder, anxious and paranoid as well. Revolving door patient, been in the service since she was 17 when she actually stabbed an old lady. And readmissions are becoming more and more. So what will we do with that? So she's not compliant with the medication. Early intervention team won't accept her because the first presentation was when she was 17. Forensic team don't think she meets their criteria anymore. She constantly requests changes in the medication. She had no insight into why she needed to take medication or into her own mental health needs. Partner, who she'd been with since they were living, looked after children, their relationship was breaking down, so that made her accommodation unstable. And we moved her into supported accommodation where she didn't feel safe and she didn't feel supported. So we purchased an independent forensic psychological assessment because she'd moved around inpatient psychiatrists and no one could really make her mind up what was going on. So we brought in an independent professor with a really good reputation, chosen carefully. And he did a really comprehensive report, and he went through the report with us and he went through the report with her. So we shared that with the care team out into the community as well. And basically, because we thought we were treating schizophrenia, and some people thought we were treating personality disorder, and what we were getting was a psychosis, anxiety increased the psychosis, which increased her anxiety, which increased the psychosis. So she was in this massive, massive cyclone, and she just couldn't get out of it. So we intensively worked with her, we kept her on the lodge, and bearing in mind we have an average stay of about 18 to 20 days, she was with us nearly a year. So we intensively worked with her, and we worked with a partner in that time as well, and their relationship actually built up again. And we gave her the magic one question, what do you want from us? And what she's saying is, she's got no family. She felt that we were a family and we were the only people who made us feel safe. So what could we do about that? We gave her open access to the acute staff 24 hours a day. She didn't have to wait to be in crisis. She didn't have to present in crisis. She didn't have to wait for a care coordinator to come to work on a Monday morning. She could come back to the lodge. She could come in on the cooking days because she was cooking with us. She could come in on a weekend for lunch. Sounds great. Staff went, oh my God, how are we going to manage this? So some of the things they came up with was not insured. What if she won't come home? What if she hasn't got a lift home? What if we're busy? What about other patients' confidentiality? She's not an inpatient. She's too complex. And so it was all about the attitudes and the values. So we turned around and said, we've got insurance, we're a hospital. She wants to go home. And if she doesn't, why don't you explore the reasons why she doesn't want to go home? Pick her up, drop her off, we've got a water car. We might be busy, but we're preventing the relapse in the mental health. And she's a service user as well. So we worked with staff around their anxieties, bearing in mind the acute staff, they're doing crisis, but doing own treatment as well. It worked really well. One of the things was, well, she'll never leave us. So what we said was, if we give her this service, we don't think she'll use it. So we used her as a benchmark, and we opened it up to other people, mainly people that were working with complex needs around personality disorders, and it was people who constantly presented crisis, 2 o'clock in the morning, Saturday afternoon when the care coordinators aren't around. People who live lonely lives, are out there on their own in the communities. Staff's attitudes are completely relaxed towards this now. We've been doing it for about 3 years now. I think we've been doing it 2 or 3 years. Staff at first took it bull by the horns and they invited everybody back. So everyone who was getting discharged onto home treatment popped back. Well, that was great, but on a Saturday we couldn't cope with the people coming through the door. And it was the people who didn't need that service that were actually accessing it. People who were pottering around on a Saturday and walking up the top of the lane, coming back, which we don't mind because we have a lot of people who come back and see us. It's not a problem at all. So we calmed that situation down and just deliver the service for the people who really, really need it. 2011-12 report from the Care Quality Commission highlighted what we were doing. I was quite proud because that was actually my work to pop that for coffee. It's my claim to fame. And the readmission rates, obviously they've spiked a bit, but they're quite low on readmission rates. And I've done, because that whistle top